Gracias por la invitación, pero el problema es no puedo hablar en español, por eso voy a presentar en inglés. Thank you, Dr. Demirci, for such a wonderful introduction. You're far too kind as always. I will begin sharing my screen here, and I will be talking today about the management of radiation retinopathy. And here are my financial disclosures, but they are not relevant to the current talk. Okay, so I think radiation-induced complications is probably the most appropriate way to describe some of the factors that we see. So we often call it radiation retinopathy, but in reality, there's a number of factors that can develop as a result of radiation damage. So they include cataract, truly radiation retinopathy with various pathogenic features, including microaneurysms, neovascularization, and vitreous hemorrhage when it becomes more significant. And so here are some examples of radiation retinopathy where you can see retinal hemorrhages here on the left side of the photo, as well as some cotton wool spots and some hemorrhage over the surface of the optic nerve as well, both in situations of melanomas that have been previously treated. We also have radiation papillopathy, which can be shown by ill-defined optic nerve margins and swollen optic nerves. And so here are two examples. The picture on the left is from somebody who received teletherapy for vitreoretinal lymphoma, and you can see they've had a good response. They have had blurring of the optic nerve margins. And then this patient here with, again, nerve swelling and significant exudation of the nerve. And then we have radiation maculopathy, where you'll get intraretinal or subretinal fluid, a loss of the normal contour of the retina, retinal thinning, and then atrophy. I think it is important to kind of define these characteristics, because I think a lot of the studies that we have are not very specific in what is meant by radiation retinopathy. And so when we're looking to characterize this and we're determining how patients respond to treatment, it becomes a little challenging if we're not all using the same definition. So what determines who develops radiation retinopathy? We know that the radiation dose is something that's significant. So obviously it's an accumulation of the total radiation dose. It's thought to be that over 35 gray is where it starts to become more significant. However, I think we've all seen patients that have been treated with lower doses than that, that do develop radiation damage and radiation effects as well. The tumor location is obviously important. The closer the lesion is to the optic nerve or the macula, the more likely there is to be a negative impact on the vision. And then there's some of the systemic effects. So diabetes, hypertension, anything that causes any level of vascular compromise, as we know that radiation damages the pericytes and leads to damage of the endothelial lining of the blood vessels. And these other systemic factors can contribute to the same processes. And then we have radiosensitizing medications, and this is particularly challenging because often in our population, they may have other cancers concurrently and may have previously received chemotherapy, and that makes them a little bit more sensitive. And then the last would be other ophthalmic findings, and those are kind of factors like a large exudative retinal detachment or a break in Bruch's membrane, which realistically may be representations of just an increasing tumor size, and so that may not be an independent factor on its own. So here's an example of a patient from our clinic, where you can see in the picture in the top left, they had a previously treated melanoma that was treated with stereotactic radiation, and at that time they were doing fairly well. Now, by the time I saw them, they had developed a recurrence of the lesion with some exudates around the lesion as well. And you can see that already by this time, they have significant vascular dropout and ischemia in the areas of previous treatment. So we treated the patient with a plaque, and you can see while there's fantastic regression of the lesion, the optic nerve is now completely pale and there's significant vascular ischemia for the superior 180 degrees. The patient decided at this point that they weren't interested in laser treatment for the ischemia because the eye hadn't seen well for some time. And you can see over time vitreous hemorrhage developing from proliferative radiation retinopathy. Fortunately, with just observation, the hemorrhage actually cleared, and 3 years later, she has not developed neovascularization of the iris or glaucoma, but that is a factor that's possible. And so this is kind of one of the potential courses in patients. Here's another patient that we saw with a very large inferior melanoma and an exudative retinal detachment. Now, they responded very well to treatment, but it's no surprise that you can see here on OCT angiography that there is significant capillary dropout from the area from the radiation that was performed. And you can see there's also a significant amount of macular edema there on the B-scan slice inferior. Now, the challenge is if you're treating this patient, they may not improve very much in their vision because they have such significant capillary dropout. And so this is a factor that we pay attention to as well. Here's another patient who has a very large melanoma and a prominent exudative retinal detachment post-radiation. And again, early on, you can see some increase in the foveal avascular zone. And so there can be a decrease in vision from the radiation effects, even without a significant amount of intraretinal or subretinal fluid. And so sometimes the OCT alone may not be sufficient to let you know what's going on with the vision or why the vision is so affected. Well, what causes these effects? We have an understanding that vascular endothelial growth factor, or VEGF, seems to play a pretty prominent role. So here is a study from 2006 that looked at a number of patients of different backgrounds. And what you can see is here in the control eyes, those were patients who only had cataract surgery. There really was not much VEGF in the anterior chamber of those eyes. However, in patients with untreated melanoma, there was quite a bit of VEGF, and even more so in patients that had treated uveal melanoma. So it seems that the effect of the radiation and possibly some inflammation from the tumor afterwards increased the amount of VEGF that was present. And so we know that VEGF plays a large role. However, in another study here that you can see, VEGF is not the only cytokine that is increased in patients with radiation effects and previously treated uveal melanomas. You can see that there are a number of other factors that play a role. So when we think about the process of treating these patients, VEGF or anti-VEGF agents will likely be of benefit. However, looking at the entire inflammatory cascade and considering the use of steroids may also be beneficial. So in managing these patients, there are a few different options that we have from a treatment standpoint. So there's laser treatment, as we discussed on that previous patient with significant ischemia, to see if that would be beneficial to prevent the development of proliferative radiation retinopathy. There's intravitreal injections of anti-VEGF agents and corticosteroids. And then there's the possibility of, very large tumors that can cause tumor lipid exudation syndrome or toxic tumor syndrome. You can consider endoresection in those cases to try and reduce the inflammatory drive. Then there's the consideration of prevention. Again, laser has a potential role, intravitreal injections, and then considerations at the time of surgery to try and reduce this. So we'll go through some of the studies and the information that gives us our knowledge about treatment options so far. So there's a number of studies that have looked at current treatment of radiation maculopathy. And again, the definition of radiation retinopathy varies between studies, so it can be a little bit difficult to pin down the response. And also, I'm not sure what things are like in Latin America, but in the United States, it can be a little challenging because insurances don't always authorize certain medications for treatment of this condition. So here's a study by Paul Finger and others looking at 99 patients who developed radiation retinopathy. And you can see that the injection timetable varied between every 4 weeks to every 3 months. And some patients required a dose escalation of medication over time. So what we can see is that the amount of fluid seemed to decrease over time with the intravitreal injections. And while that looks pretty good, we can see that over time, the visual acuity continued to get worse, even in the setting of decreased central foveal thickness. Now, it's not a surprise, as we showed in the earlier photo, that there can be capillary dropout and ischemia that develops as well. And so you can see here that while some of the clinical signs of radiation retinopathy go away on clinical exam from left to right, that does not necessarily mean that the effects of the radiation have not continued to progress from an ischemia standpoint. Well, people have also looked at steroid injections to see if that would be of any benefit. And in particular, this study compared ranibizumab versus dexamethasone or a Ozurdex implant to see if there would be any difference between the outcome for the patients. So tumor thickness and distance to the fovea were pretty similar. Time to development of radiation retinopathy between the groups were also similar. And the treatment algorithm for ranibizumab was 3 monthly injections followed by PRN dosing. And the Ozurdex implant was a single injection, with PRN dosing afterwards. And so there was a little bit of a longer follow-up for those that were treated with ranibizumab, but you can see that the number of injections of patients with ranibizumab was a little bit more in both year 1 and year 2. Well, in terms of the outcome, the visual acuity improved in both groups, and there was no difference between the two. The central macular thickness decreased in both groups. Again, no difference between the two. And so they seem to be equally effective, with dexamethasone requiring less injections. Here's an example from my clinic of a patient who developed significant intraretinal fluid, presumably from the radiation, although it does look like the vitreous is connected at the fovea, and so that may have contributed to some degree. So they got a couple of injections of anti-VEGF agents without a significant response, but after dexamethasone, you can see that there was quite a nice response with resorption of the fluid. But what you also can notice is how hazy the picture is now, and that's because they've obviously developed a cataract. And so there is the consideration not only of cataract development, but also the increase in intraocular pressure and the effects that that has. And so that's something to keep in mind when considering anti-VEGF versus steroids. The next option is the consideration of surgical intervention for these patients. So this is the patient that I showed earlier, and you can see initially after plaque treatment, you can see that the tumor regressed nicely, but there was an increase in exudative detachment now approaching the fovea. And given the size of the lesion and the concern for tumor lipid exudation syndrome, they underwent an endoresection. Early on with oil in the eye, you can see some hemorrhage, but later on, they actually look quite good. So there's significant regression of the lesion after the endoresection, and the laser shows that the retina is nice and flat with the oil being removed. However, the vision was limited in this patient somewhere around the 2100 range, and perhaps that's better than it would have been if neovascular glaucoma had developed, but I think it's a little bit hard to say overall. And we also know that there are some potential complications of doing this with the consideration of tumor dissemination, which is why, at least in my hands, we only do that after radiation, but there's also the consideration of air emboli when you have open choroidal vessels. Looking at prevention of disease, scatter laser has been assessed. Again, Paul Finger et al. Looked at 66 patients that had uveal melanoma and specifically focused on a subset of 16 patients that had prophylactic treatment. Only one of the patients developed radiation maculopathy, but 2 patients developed retinopathy outside of the macula, and no patient lost more than 3 lines of vision. However, there were only about 2 years worth of follow-up, and we know radiation retinopathy can continue to develop afterwards. So this is something to keep in mind. Here's a couple of examples of how scatter laser can be considered. So we know, at least when we're doing plaque radiotherapy, there's a 2 millimeter margin around the lesion. And so providing laser in that area will hopefully reduce the areas of ischemia. However, you can also do wide field fluorescein angiography to look at ischemia and kind of treat the entire area where there's signs of ischemia. Additionally, you can see laser is performed over the area of the tumor because presumably the retina that's overlying the tumor is viable and can send out the signal for VEGF and other cytokines. Looking at steroids in a prophylactic manner, this was done out of the Shields group, and they looked at 163 patients in a prospective study looking at subtenon's injection of triamcinolone at plaque application 4 and 8 months. And while you can see there were good responses in terms of a reduction of intraretinal fluid development and a reduction in the amount of vision lost, intraocular pressure increase was double in the treated group. And actually 11 of the patients ended up withdrawing from the study due to an increase in intraocular pressure. So this is something that is a reasonable approach, but considering cataracts and the possible development of glaucoma, there's a possibly dose reduction of medication or determining how frequently that medication should be given. And because of those complications, anti-VEGF has been studied a little bit in the prophylactic approach. Earlier in the year, Dr. Shields came on and she gave her talk about this study, looking at over 1,100 patients that had prophylactic injections of anti-VEGF, of bevacizumab. And you could see that at 4 years, the control group had visual acuity of counting fingers versus 20/70 in the treatment group. Now, while there is a lower risk of macular edema, papillopathy, and proliferative radiation retinopathy, there was still a similar development of neovascularization of the iris and glaucoma over time. There's also the possibility that if you're following patients this closely with intravitreal injections, you might not only be reducing the risk by treating prophylactically, you might be identifying patients who develop radiation retinopathy earlier, and therefore you can switch to monthly injections or other things at an earlier time frame. And so it's hard to tell what the exact benefit is, but it does seem like it helps. That study information was also confirmed, or at least reinforced, by the group out of Mass Eye and Ear, where they looked at a similar approach using ranibizumab instead. And you could see that for small melanomas, it reduced the risk of radiation retinopathy development, and definitely so for large melanomas as well. So what other approaches do we have from a prophylactic perspective? Some people in the United States, at least a few groups, have looked at how silicone oil can reduce the risk of radiation retinopathy development. And so in vivo, studies have shown if you look at different areas of the eye, the radiation can be attenuated by silicone oil. And as a result, the group, particularly in UCLA and also a group in Denver, often places silicone oil after biopsy at the time of plaque application to try and reduce the risk of radiation damage. And if there's a concurrent exudative retinal detachment, they will also treat that at the same time. Now, I think there are some potential challenges or complications with that, as some patients do develop retinal tears. And out of the 20-patient study on the bottom in the 1-to-1 match control series, 3 patients developed intraoperative tears, 1 patient developed a macular hole, another developed an epiretinal membrane. And so there are possible complications. And so it kind of requires balance in the risks versus the benefits of that approach. So at least our current algorithm here in Cincinnati, we do give a subtenon's Kenalog at the time of plaque placement, varying the dose based on the size of the lesion. We do give an anti-VEGF at the time of removal, but considerations for that in the future really depend on the patient, how extensive the lesion is, and the location of it. Prophylactic laser we consider at the time of plaque removal. However, if they have a large exudative retinal detachment, that can't be done, and that requires follow-up in the clinic. So what about future directions for radiation retinopathy? The use of OCT angiography can be potentially helpful for us to understand the process that radiation, the role that radiation plays in vascular damage and how that affects vision in the long run. It'll also be interesting to see if there's any correlation between intravitreal injections of anti-VEGF and steroids, and if that does anything to remodel the vasculature or reduce the risk of development of radiation retinopathy. We also know that the DRCR Retina Network, which has done a number of studies, is actually starting a prospective study in the United States at a bunch of centers looking at prophylactic and injections of anti-VEGF and steroid injections to see how it affects radiation retinopathy, to see if we can actually get a large number of patients and assess whether or not it makes a difference. And then we also know, coming down the pipeline through a lot of studies of macular degeneration and diabetic retinopathy, that there's a lot of longer acting medications that play a role both in steroids and anti-VEGF medications that are coming out in the near future. So it'll be really interesting to see how those medications work and what applications there will be for the radiation retinopathy population. So that's kind of the end of my talk. I'd like to thank Dr. DiNicola, my partner in practice here, who helped me with this presentation. And I will turn over the floor at this point to the moderators. And once again, I appreciate the invitation to speak with you.
Thank you, Basil. That was a really nice talk. I have a practical question for you. So in my practice, when I'm dealing with patients who are pretty long-term out from their plaque radiation treatment, we often get into this cycle where we feel kind of stuck with the radiation retinopathy management. So we're doing anti-VEGF injections. They've had a sector PRP and they're doing overall pretty well, but you know, there's still a lot of ischemia there, even though you've tried to laser it very well. And you're maybe out to every 12 weeks on their injection. And the patient asks, do I have to be on these forever? When can we stop? And I've seen so many times where I've been burned, especially with this pandemic, of patients who can't come in and then they come back with vitreous hemorrhage because they've been off of these. So what do you tell patients when they ask you this, and when do you feel safe stopping anti-VEGF?
Yeah, that's a fantastic question, and honestly a really challenging scenario for patients. So one of the biggest challenges in this scenario is, after dealing with cancer and kind of emotionally feeling good about the treatment, patients really want to be done with this process. And so the idea of getting injected regularly for many months to many years down the road can be a huge burden emotionally. I usually tell them that this is something that may need to be treated for life. However, the decision is ultimately theirs. And as we extend, if we end up having to stop treatment and they do develop edema, and the ischemia continues, there's a possibility that they lose vision that we cannot get back in the future. And so while I'm willing to work with them, I just want them to understand the risks. And then if that's something that happens, then they know that that can be an effect. But I agree with you completely. That's a really, really challenging scenario. So.
I definitely agree. Like, to stop the treatment is a very interesting. And the other question is, like, by giving the anti-VEGF or steroid, are we just delaying the process a little bit, just buying time and not changing the endpoint? That where is that endpoint going to happen? Like, you see these patients come to 2200s or 2300s or 2150, somewhere there eventually. So, like, that's a good question to patient. Like, when do you reach that point? Is it good, like, the patient come to 2100 or 2150? Shall we just keep injecting the patient, or shall we just say that, hey, this is, you come to your baseline right now, there is not so much edema, shall we just stop here? I mean, that's a great point.
But that's another fantastic question. And I think if you look at macular ischemia, their vision will end up in the 2150 or 2200 range. So you perhaps are not improving their vision. I think the only consideration or conversation I have then is the possibility of neovascularization or neovascular glaucoma. And so I just have that conversation as well. But I agree with you completely that it is a really difficult scenario.
And the other question is when to start the injections. Like, do you start after you give the plaque or external beam radiotherapy? Do you start to give these patients anti-VEGFs after the treatment at certain intervals, or do you wait to see the vision decrease or edema developed or the first sign of the radiation retinopathy? When do you start? Or Lauren or anyone else can tell their experience when to start the injection. That's the other point.
Yeah, I mean, that's another great question. And I think this is a conversation that I have with the patient, and I kind of ask them how they want to approach it. Now, if it's a large lesion and it's posterior and it's close to the macula, I think they're really likely to develop radiation damage. And maybe we're only delaying a decrease in vision. But I think that's valuable for at least some time, especially if the patient's older, especially if they have high-risk disease, then maybe we're improving their lifestyle for some period of time before metastasis develops. But I offer treatment early on. So I offer treatment immediately after plaque, especially for larger posterior lesions. If they're small and peripheral, I'm not sure there's much of a benefit. They may never develop any problems. And then I also let them know that if we don't do the injections and their vision decreases, we can start injections. We may not be able to get it back to baseline, but even if we do injections from the beginning, we may not be able to keep the vision at baseline. So I don't think there's a clear answer. And I'm really looking forward to the DRCR study, so that way we can hopefully get a little bit more information about it.
Awesome. So thank you very much. I think we're going to move on to our next talk. And if we have time at the end, we can always come back to more questions. Really nice job, Basil. It's my pleasure now to introduce Dr. Carolina Hensail, and she is an ocular oncologist at the Hospital Italiano de Buenos Aires in Argentina. And she's another one of our stars in the field. I am really excited. She never disappoints. So we're going to hear her talk on the differential diagnosis of melanoma versus pseudomelanoma.
Hello, thank you very much. Bueno, muchas gracias a todos por aquí presentes, a los coordinadores, y ahora voy a compartir pantalla. Bueno, voy a hablarles en español. Bueno, perfecto. La idea de hoy es hablar un poco sobre los diagnósticos diferenciales de melanoma uveal y pseudomelanomas. Los objetivos de esta presentación van a ser enumerar los posibles diagnósticos diferenciales del melanoma uveal, describir las patologías más importantes a través de algunos casos clínicos, e identificar las características clínicas de las lesiones más frecuentes. Cuando hablamos de diagnósticos diferenciales de un melanoma uveal, uno plantea posibles diagnósticos de lesiones tumorales, benignas o malignas, como también de otros diagnósticos de lesiones no tumorales, por ejemplo, hemorragias, patología inflamatoria, infecciosa, entre otros. Ya que, como todos sabemos, el melanoma no siempre es pigmentado, a veces tenemos melanomas amelanóticos, y muchas veces hay ciertas características que nos pueden hacer dudar del diagnóstico. Para ello, ¿cómo llegamos al diagnóstico de este tipo de lesiones? Recordemos como oftalmólogos la importancia del interrogatorio, el examen completo con fondo de ojos y también estudios complementarios como la ecografía ocular e imágenes multimodales, todo dependiendo de la sospecha diagnóstica. Muy bien. Ya en el año 2014, el grupo de la doctora Shields publicó un trabajo sobre el melanoma coroideo y sus diagnósticos diferenciales, analizando 12.000 pacientes referidos en un periodo de 25 años. 1.739 fueron diagnosticados con pseudomelanoma. ¿Y cuáles eran esas lesiones? En primer lugar, la mayor cantidad de los pseudomelanomas que fueron derivados, o que uno tiene que tener en cuenta, es el diagnóstico diferencial o la diferencia entre neus y melanoma, seguido de corioretinopatía periférica, exudativa hemorrágica, hipertrofia congénita del epitelio pigmentario, desprendimientos hemorrágicos, ya sea de retina o del epitelio pigmentario, hemangiomas coroideos, maculopatías y otro tipo de tumores, como por ejemplo metástasis. Vamos a ver ahora algunos casos clínicos que fueron referidos a nuestra institución, al Hospital Italiano en Buenos Aires, con diagnóstico de melanoma, y otros que quizás no tenían ese diagnóstico y fueron, diagnosticados como melanomas. Veamos este primer caso. Es un paciente consultado en época de pandemia por WhatsApp por otro colega, otro retinólogo, con sospecha de diagnóstico de melanoma en su ojo izquierdo, y dudaba en su diagnóstico, sobre todo, y en la evolución. ¿Por qué consultó por WhatsApp? Además de la duda diagnóstica, es porque encontró esta otra lesión en el otro ojo, en su ojo derecho. Recordemos que esta no es una imagen color, sino es una imagen multicolor, que muchas veces puede sembrar ciertas dudas. Bueno, el hecho es que vino al servicio de oftalmología de nuestro hospital y obviamente fue evaluado. Tenía antecedentes de pseudofaquia, de hipertensión, 4 stents cardíacos, diabetes, tabaco y cáncer de próstata tratado años atrás. Fíjense, acá podemos observar la ecografía, donde vemos una lesión de media alta reflectividad sin líquido subretinal ni excavación coroidea, con lo cual se descarta el diagnóstico de melanoma. Y la otra lesión que sospechaba el otro colega era claramente una retinosquisis. A lo largo del tiempo, la lesión primaria del ojo izquierdo se encontraba estable, en buena evolución, sin ningún signo de progresión. En este caso es otro ejemplo de una paciente de 70 años con maculopatía y una hemorragia vítrea que fue cediendo, y encontramos esta lesión periférica con algunas áreas de alteración del epitelio pigmentario. En la ecografía vemos una lesión sólida de reflectividad más alta con una imagen tipo membrana compatible con una asquisis. Le realizamos una ecografía Doppler para evaluar vascularización, la cual no presentaba, y por otra parte esta paciente fue seguida en el tiempo, 2 años después, con, estable y con buena evolución. Entonces, estos dos casos mostraron esta patología, que es bastante frecuente como diagnóstico diferencial, que a veces llegan a nuestro hospital, que es la corioretinopatía periférica exudativa hemorrágica, que es una vasculopatía retinal, en general está en periferia, es similar a la maculopatía, o sea, una neovascularización pero a nivel periférico, y se presenta sobre todo en hipertensos, en mayores de 60 años y más en mujeres. Puede aparecer con hemorragia vítrea, con hemorragia subretinal o subepitelio pigmentario, y en algunos casos exudación. Los estudios complementarios son muy importantes, sobre todo la ecografía, la angiografía fluoresceínica y en algunos casos también la indocianina, que bueno, en Argentina no contamos o se realiza muy poco. No olvidemos continuar el seguimiento, no olvidemos, realizar el seguimiento, porque a veces no es un dato menor que hay algunos pacientes que presentan lesiones similares y que, bueno, a lo largo del tiempo puede aparecer o puede, digamos, sí, aparecer un melanoma. Este es otro ejemplo, fíjense, una paciente de 62 años, a veces los que hacemos oncología ocular nos pueden referir o pueden preguntar por este tipo de lesión, pero esto en general no trae ninguna duda, es una lesión bien circunscripta, localizada, con estas áreas lacunares, como podemos ver acá. Esta es una paciente con una hipertrofia congénita del epitelio pigmentario, como vemos en estos otros casos. Ahora, ¿qué pasa en este caso? Que es una paciente de 28 años, también con lesiones parecidas, pero con una forma más ovalada o pisiforme, ¿sí? Y en este caso, por la edad y por antecedentes, estaba asociado a una poliposis adenomatosa familiar, con 100% de penetrancia. Es muy importante en estos casos, cuando vemos lesiones múltiples, con esta forma, preguntar sobre antecedentes de cáncer de colon en la familia. El OCT también nos ayuda a evaluar los cambios a nivel del epitelio pigmentario. Obviamente, esta paciente fue referida al gastroenterólogo y también es posible realizar estudios genéticos. Veamos este otro caso. También, fíjense, una paciente de 38 años, referida para realizar una ecografía por una cirugía de catarata. La paciente presentaba como antecedente miopía, menor visión en el ojo derecho de 6 meses de evolución. El interrogatorio fue dificultoso, pues la paciente no hablaba español, una paciente oriental, y no podía comunicarse, si bien venía con su intérprete. Pero tenía una agudeza visual de percepción de luz y en el ojo izquierdo de 20/20. Ahora bien, ¿qué es lo que nos resulta llamativo en el interrogatorio de esta paciente derivada para evaluar cirugía de cataratas? Primeramente, además de la edad, no tenía ningún antecedente ni de trauma, ni de corticoides, nada que pudiera sospechar que podría tener una catarata. Esta era la biomicroscopía y el ultrasonido. Fíjense, en la biomicroscopía no se ve el cristalino, digamos, con mayor opacidad, sino que es como más posterior. Y vemos toda una lesión, o sea, casi ocupando toda la cavidad vítrea, algo más heterogéneo. Se le realizó una resonancia magnética que se veía una formación hipointensa en T2, hiperintensa en T1 y ligeramente heterogénea. Las estructuras orbitales se encontraban conservadas. Incluso en el informe nos hablaba de, podría corresponder a un melanoma como también un hematoma, con lo cual realizamos una ecografía Doppler. ¿Por qué nos ayuda? ¿Por qué nos basamos en este estudio? Porque evaluamos la vascularización adentro de la lesión. En general, al ser un tumor, es un tumor vascularizado con, digamos, con vasos en el interior, a diferencia de, por ejemplo, un hematoma donde no encontramos ese tipo de vascularización. En este caso, bueno, la paciente fue nucleada y el diagnóstico fue de un melanoma necrótico. Veamos este otro caso como diagnóstico diferencial de un melanoma ovial. Fíjense, esta paciente es una paciente de 53 años que fue operada en otro centro por facorefractiva. Acá pueden ver la imagen de una lente multifocal. Se operó de los 2 ojos, pero ella consultaba por teleconsulta, ya que el ojo derecho veía bien, pero el izquierdo no terminaba de mejorar su visión. Así es como apareció en nuestro centro, con esta imagen, con esta congestión a nivel del ojo izquierdo, y fíjense, en el fondo de ojos vemos un desprendimiento de retina y una lesión aquí a nivel nasal. La lesión, digamos, fue progresando mientras lo estudiábamos, ella digamos, se encontraba en controles. Esto fue en plena pandemia, donde en nuestro país estaba todos los centros prácticamente cerrados en cuarentena, con lo cual era difícil el acceso. Pero bueno, la paciente fue evaluada y fíjense en la OCT, como vemos, el ojo derecho bien y el ojo izquierdo, este patrón ondulado, este contorno anterior irregular que nos llama la atención, tipo lumpy-bumpy. Esta es la ecografía y el ultrasonido. Vemos una lesión difusa, con engrosamiento coroideo, sólida, con desprendimiento de retina, exudativo. Fíjense el lente estaba tilteado por una lesión, ¿sí? Por un tumor a nivel nasal. Y acá les muestro un video, ¿sí? Donde podemos ver la lesión propiamente dicha a nivel, digamos, de cuerpo ciliar, alterando el ángulo y la formación, y vemos que a nivel posterior también tenía un engrosamiento coroideo, es una lesión difusa con un desprendimiento de retina exudativo acompañándola. Muy bien. Bueno, se realizó todo un screening, cuando uno tiene este tipo de lesiones, por más que, digamos, se realiza todo un screening, y encontramos que presentaba esta lesión sólida a nivel, o sea, este tumor a nivel del área pulmonar. Bueno, se realizó una biopsia de este sitio, se realizó todo un examen oncológico, y el diagnóstico fue una metástasis de carcinoma de mama. Lo cual, bueno, fue tratada con inmunoterapia con buena evolución. Entonces, cuando hablamos de metástasis coroideas, que es uno de los tumores intraoculares malignos, digamos, más frecuentes que podemos observar, es importante evaluar cuál es el tumor primario de origen, y lo más frecuente es la mama y el pulmón, como en estos tres casos son pacientes con metástasis de cáncer de mama. Pero también tenemos otros tumores que pueden dar metástasis a nivel coroideas. Por otra parte, también es importante que a veces el oftalmólogo es el primero en reconocer y sospechar estas lesiones, porque muchas veces no tienen la historia, digamos, de una enfermedad metastásica o de un tumor primario, y el oftalmólogo es el primero que diagnostica este tipo de tumores. Hay un 34% de casos que preceden al diagnóstico del tumor primario. ¿Y cómo son estas características? O sea, ¿cómo vemos las metástasis? O ¿cómo las podemos observar clínicamente? Generalmente son lesiones blanquecinas, amarillentas, fíjense, algo más difusas, con un patrón más heterogéneo, donde presentan abundante líquido subretinal. Algunas se presentan con una piel más de leopardo, como se la llama, e incluso con algún moteado característico. No todas son de color claras o amarillentas, que a veces uno tiene que hacer el diagnóstico diferencial, por ejemplo, con un melanoma melanótico. Muchas, otro tipo de metástasis tienen un color más anaranjado, por ejemplo, las que son de tumores renales, tiroideos o de carcinoides, o algunas son pigmentadas, como por ejemplo las metástasis de carcinoma de piel, de melanoma de piel, perdón. Bueno, ¿cómo hacemos el diagnóstico? El diagnóstico se hace por la historia clínica y el interrogatorio, por el examen del fondo de ojos, por el ultrasonido, que es característico. La ecografía en el melanoma tiene ciertas características de media-baja reflectividad, excavación coroidea, movimientos vasculares, a diferencia de las metástasis, que son lesiones un poco más planas, más irregulares, la reflectividad es más media, ¿sí? Como podemos ver en este caso, y en OCT vemos este patrón de contorno irregular anterior. Veamos este otro caso. Esta paciente consultó también a nuestro hospital de un país vecino, tiene 64 años, y consultó por una revisión del ojo derecho con diagnóstico presuntivo de melanoma. Pero ya viendo el fondo de ojos, si bien la base es una base más pigmentada, vemos que la coloración es más, digamos, más rosada, más anaranjada. Y vemos la angiografía fluoresceínica, donde comienza a tener una hiperfluorescencia más precoz, una filtración tardía, y en la ecografía lo característico es la lesión sólida, pero de alta reflectividad. Aquí estamos en presencia de un hemangioma coroideo, con lo cual tiene otro tipo de tratamiento que, bueno, no voy a explicarla ahora, ¿sí? Fíjense, vamos a ver, esta es la paciente, es una lesión homogénea, podemos ver acá el video, no tiene ni excavación coroidea, ni movimientos vasculares espontáneos, ni nada que asemeje un melanoma uviar. Vamos a ver este otro caso, donde vemos un paciente de 52 años de edad con una lesión pigmentada desde el 2012. Lo importante siempre es documentar las lesiones. Más allá de uno evaluarlo, anotarlo en la historia clínica, siempre tener registro de las mismas. A veces uno tiene a mano una posibilidad de realizar una retinografía color, pero a veces no es disponible, o sea, no disponemos, sobre todo en nuestros países o en el momento de la consulta, y aunque sea, uno puede documentarla, incluso hoy en día con tecnología, o sea, con celulares y una lupa de 20, antirreflejo puede, aunque sea, documentar estas lesiones. ¿Por qué es importante? Porque uno tiene que ver si hay cambios, el seguimiento, más allá de todos los estudios que uno haga, desde ecografía, imágenes multimodales, en el caso que lo amerite. Este paciente, por ejemplo, tenemos la retinografía color, prácticamente no presentó evolución, si bien tiene cierto espesor, no tiene líquido subretinal, que es uno de los factores de riesgo, con lo cual uno realiza los controles en forma, digamos, periódica. Y siempre medir la ecografía y documentar, como dije previamente. Ahora, veamos este otro caso. Esta es una paciente de 27 años, donde tiene una lesión pigmentada, con pigmento naranja, ¿sí? Es pequeña, pero por la ecografía tenemos una lesión de baja reflectividad, que medía algo más de 2.2 milímetros de espesor, pero vemos de baja reflectividad por ecografía, ya sea modo A, estandarizado, o modo B. En este caso, tenía además líquido subretinal con los J photoreceptors, ¿sí? Incluso a nivel central, a nivel macular, y tenía varios factores de progresión. Bueno, si bien fue una lesión pequeña, a esta paciente le hemos colocado una placa de braquiterapia. Acá están los factores de riesgo, digamos, de progresión, que muy bien, tenemos acá la moderadora, la doctora Delvin, que ha hecho un trabajo espectacular con ello, al respecto. Y bueno, esta paciente fue tratada con braquiterapia, y fíjense que al año y medio del tratamiento, a pesar de ser un tumor pequeñito, en este caso sí era un melanoma y no era un nevus, la paciente apareció con una metástasis a nivel hepático. Y este es otro caso de una paciente de 64 años que fue tratada con antiangiogénicos por maculopatía por especialistas de retina. Esos los estudios que trajo a esta paciente, tanto desde el año 2017, fíjense, vemos una elevación a nivel, acá con sombra posterior, fíjense el líquido subretinal, pero estos son todos estudios que trajo la paciente. Estos eran del 2018, esta era la ecografía que presentaba, y a nosotros nos consultó recién 2019, pero fíjense que ya es una lesión obviamente más grande, con excavación coroidea, con líquido subretinal, bueno, obviamente pigmento naranja, tiene todas las características y baja reflectividad. Bueno, esta es una paciente con un melanoma coroidea. Entonces, ¿qué quiero decir con esto? Que a veces derivan pacientes con sospecha de melanoma y no lo son, es decir, son pseudomelanomas, pero otras veces hay que tener mucho cuidado con pacientes tratados por otras patologías que quizás no se sospecha y presentan o tienen un melanoma coroideo. Bueno, esta es la evolución, la paciente fue, digamos, se le ha colocado una placa de braquiterapia, bueno, con buena evolución, mejorando la reflectividad, todavía está en seguimiento. Entonces, como conclusión, siempre es importante considerar las lesiones tumorales y pseudotumorales como diagnóstico diferencial de melanoma coroides o uviar. Pero también consideremos estas lesiones, las que no nos refieren como neoplásicas y sin embargo presentan o melanomas u otro tipo de tumor. O sea, y ante la duda diagnóstica siempre es importante el seguimiento y el follow-up con una buena documentación. Hay que realizar un examen oftalmológico completo, nos podemos ayudar de acuerdo a la sospecha o duda diagnóstica en estudios complementarios, obviamente ecografía ocular, OCT, otras imágenes multimodales, y el seguimiento de los pacientes es muy importante y sobre todo también el buen trabajo en equipo. Bueno, muchas gracias a todos por su atención.
Really nice talk, Carolina. Beautiful, beautiful cases. I love all those pictures, and you're improving my Spanish, so thank you for that. You touched on probably the most common pseudomelanoma diagnosis that I get, which is peripheral exudative hemorrhagic chorioretinopathy. What's your advice to somebody who's trying to suss that out at home, who maybe can't get their patient to one of us who's very familiar with that on their own? What's going to be their #1 ancillary test to get, and what's going to be their key distinguishing features?
Sorry, can you repeat this?
Yes. So tell us a little bit about peripheral exudative hemorrhagic chorioretinopathy. If you had to tell someone who's not quite as comfortable distinguishing that from a melanoma lesion, what test they want to get and exactly what they're going to look for, what's their key?
Okay, thank you. I will answer in Spanish, okay? Well, primero, siempre realizamos el fondo de ojos con una buena ecografía. Habitualmente todo lo hacemos en el mismo momento. Pero nosotros en el hospital, cuando tenemos una lesión, digamos, elevada, con sospecha, y que no sabemos distinguir, nos basamos mucho también en la ecografía Doppler, que la hacemos en el hospital italiano. ¿Por qué? Porque eso nos evalúa la vascularización adentro de la lesión. Una de nuestro equipo de oncología ocular se acerca al ecografista general, o sea, por eso es importante lo que hablaba muchas veces de trabajar en equipo, y vemos juntos las imágenes, evaluamos, y si todavía persiste la duda, bueno, uno hace un seguimiento más estricto a los 2 meses, a los 3, para evaluar si hay cambios. Habitualmente, esas lesiones, cuando tienen hemorragia y todo, digamos, son más elevadas, pero con el tiempo deberían disminuir y poder visualizar mejor el fondo de ojos. Muchas veces no deberían por qué crecer. Entonces, eso creo que es un dato importante a tener en cuenta.
Okay, great. I have a question, Carolina. How often do you see the hemorrhage with melanoma? Like how often is associated with hemorrhage and melanoma? Like, what do you think about that? How often do you see it?
En nuestro caso lo vemos muy frecuente, sobre todo este último tiempo. Vemos melanomas grandes con desprendimiento hemorrágico del epitelio, digamos, desprendimiento hemorrágico, y últimamente estos 2 años, no sé si es por la pandemia o demás, pero a veces son digamos, las dificultades diagnósticas que tenemos en nuestro medio. No siempre vemos imágenes pequeñas, de baja reflectividad, sino vemos melanomas muy avanzados, que incluso la ecografía no es característica, es heterogénea, hay sangrado. Entonces por eso también hacemos bastante ecografía Doppler, que nos ayuda mucho a distinguir los límites. Por ejemplo, si tenemos un melanoma vemos los vasos en la lesión, pero todo lo que es el sangrado alrededor, ahí no tiene vasos, entonces nos ayuda, es un estudio más para evaluar los límites y evaluar el posible tratamiento a considerar en estos casos.
Sorry, my Spanish is not that level right now. I missed most of it, but I will get from the Basil, from the summary.
I think, Basil, if you want to translate what Carolina said so everybody can understand it.
Okay, that's going to be a little
Sorry.
bit challenging. No, that's okay. But she was saying that one of the first things she does is gets an ultrasound with Doppler so that she's able to see the vascularization inside the lesion, and that'll help her differentiate. And then she was saying that with the large lesions, that it's more likely to see the hemorrhage in those scenarios, as opposed to the much smaller melanomas. That's the much shorter version.
What about the transillumination? I think, does she use the transillumination also in some lesions for that one, especially in the periphery ones?
Yes, a veces lo usamos, En cirugía sí, siempre, cuando colocamos la placa, in surgery, yes, but in the clinic, maybe sometimes, yes.
I forgot to mention, these are great presentation. Your cases were beautiful cases. I mean, they are gorgeous. They're very, very beautiful cases.
Thank you very much.
What about vitreous hemorrhage? The cases, the vitreous hemorrhage, I find it a little bit more difficult to differentiate. Like those cases, you showed a great case of necrotic melanoma, but sometimes like we see these cases, they do ultrasound and they find something in the ultrasound and then they refer you like saying that, is there a melanoma here? Should I do vitrectomy or should I don't vitrectomy? What should I do for these cases? What do you do in these cases? Basil or Lauren, you guys can also make comments about what do you do in the cases with vitreous hemorrhage and choroidal lesion on ultrasound or found on the ultrasound, basically.
Well, I think those are obviously very challenging cases, and I think there's a couple of ways that I would approach it. First, it depends on some of the characteristics. So I often will get an MRI, as Carolina mentioned in her presentation, to see if that'll help differentiate. And then sometimes I do think it's helpful to try and clear out the hemorrhage to see what's going on underneath, but it really depends on the location of the lesion. So lesion localization is very important because unfortunately I've seen some patients sent to me by retina specialists where the trocar for the infusion was entered directly into the tumor. So, so in those situations, I recommend a very close ultrasound, and perhaps this is a good situation for transillumination before trocar placement. And then since there's been no treatment, I would consider doing a peritomy beforehand in the area of the trocar placement. So that way, when the trocars come out, if there's any potential seeding at the site of the trocars, that it's not trapped underneath the conjunctiva, I would do a double freeze thaw to the area of the sclerotomy, and then perhaps consider suturing the sclerotomies afterwards. But I think that doing a diagnostic vitrectomy to clear the hemorrhage and see underneath can be helpful if all the other diagnostic modalities, including MRI, are not sufficient. That's how I approach it.
Yeah, I think you hit the nail on the head there. I mean, really, it's okay to clear out the hemorrhage as long as we avoid putting any ports through the tumor. Then you can still salvage the eye in those situations. So you really haven't done damage and you've gotten yourself a diagnosis. And sometimes in that situation, I've even, you know, when our retina specialists encounter an unexpected tumor, I've even had them go and they can take a biopsy at that time. And then we can send that for our cytogenetic testing and really confirm for the patient. So everybody's all on the same page about what we're dealing with. So the key is really just to look really carefully where you're putting those trocars in those situations.
Yeah.
I think that there are some challenging cases, maybe the tiny tumors, but also the huge tumor because they are at the sides of the, so that's very challenging in some cases.
Yeah, I agree.
We had great presentations today. Anybody has any more questions? Feel free to ask. And as we think about any more questions, I'm just gonna remind you guys that we have an event coming on December. We're gonna have case presentations sent by you guys. So anybody who wants to send a case, we can record a video of 5 minutes, a clinical or surgical case for us, and we'll be able to present the best cases here in the December webinar. So we're gonna play a very fast video for you guys just to remember this. So me again, just to remind you guys that there's a prize on the best cases.
Great.
With a $250 prize for the 2 best cases we select. So please participate, please send our videos, and feel free to ask any more questions if you want. So I'll leave to the moderators, Dr. Dalvin and Dr. Dimitri.
I have one last question, if I may. Have you had a case, well, I had some, when I was a vitreoretinal surgeon, made a vitrectomy, and during the surgery, they found out they had a little tumor over there, and they've had bleeding, subretinal bleeding. They tried to drain it, and they put silicone oil, and then they send us the patient that has silicone oil, subretinal blood, and you must evaluate, and you cannot see the tumor. You cannot see the tumor, you cannot make an ultrasound. What do you do in these cases?
Yeah, these are tough cases. I think probably by our faces, we've all encountered this situation before. It's really tricky. You know, part of it depends, I think, on tumor size and what is the visual potential. If you have an eye that's just already really, really sick, then sometimes you head for a nucleation in these cases. But if it's something small where the eye can be saved, gosh, then you're kind of stuck in this place of trying to do a really careful evaluation of an ultrasound that you know is not going to be accurate, and maybe trying to supplement with MRI to see if you can try to suss out the size of this lesion and can it be treated with radiation. But those are tough.
But Melin, I had a case like that way actually. Like it is the retina surgeon did the surgery, couldn't stop the bleeding, and then like he put silicone and then still bleed, and then the inside was still like very, very Murphy bleed, and then you see the patient with no view almost. You look at the inside and then you only see something red over there, no detail at all. So how I started, I usually in these cases, like first you don't know if it is really tumor or if it is something else is bleed over there. So that's your like kind of a start point. So I start with MRI first of all, just to like kind of rule out if it is a melanoma, if it is not a melanoma, if it is something else. If it is certain size, the MRI can help. If it is not certain size, it will not help you at all. If it is small, I think I will say that, hey, let's wait a little bit, blood goes away. Maybe you can ask one of the other person by knowing, get that silicone out so we can really see what's happening inside. That's really the melanoma or not. And then if it is really big, then that's a different story, of course. That's a little bit, if it's a big size tumor, then MRI can give you some clues, and then you can start to think about different alternative actually at that point. But that's the other alternative is like if the second person goes there by knowing it might bleed, get a little bit more prepared during the surgery, take that silicone, see what it is over there, and then do a quick exam, maybe biopsy at that session. I think that's was the two-step approach basically in those patients. But that's a very difficult situation. It's a very difficult situation.
I had 2 cases just like this with a lot of blood, and both of them, well, I always try the ultrasound anyway, even with silicone oil. And in both cases, I think I saw a melanoma, but then I always go to the MRI, and it helps. Well, it helps a lot. One of them was big, so it went to enucleation, but the other one was small. I waited a little bit, and then the blood reabsorbed, and I could see a little bit of the tumor much better, and it was also a melanoma, but really tough cases.
And also like this vitreous hemorrhage, and then when you cannot see it, is the other alternative is some metastasis can appear also like this way. It is not always all vitreous hemorrhage is associated as a tumor point, is not the melanoma. The metastasis, some of the metastatic tumors can bleed inside the eye too, and that might be their first presentation actually. So in some cases, just a biopsy is a very good idea. I'm very lucky to have the Bernadette here, Bernadette Ayres, Dr. Bernadette Ayres. I'm a little bit spoiled with his support from the ultrasonography side. That's incredibly spoiled for me, but we do some of these things in the operating room together.
Very good. Thank you.
What is the most metastatic site in the South Africa, like South America? Sorry, like that from the, like here we start always with breast cancer and then the lung cancer. But what do you see in this? Is it the same or is it different kind of a metastatic pattern in the male or female? Does it make any difference?
It's more or less the same in our case. Lung cancer, it's very common, and it's very common that first we diagnose the metastasis, and then we find the cancer. I mean the lung cancer. Yes.
And do you use the photodynamic therapy for the metastatic cases, or?
We don't have that in Argentina.
Okay.
Yes, only radiation or maybe another kind of laser is described, but only more or less radiation. And sometimes it's very, for example, we have to wait the systemic response of the chemotherapy or something like that. Yes.
Because for small tumors, I start to use the photodynamic therapy. But if there's very small, not so much fluid around it, they really do for easy fixes for some patients right now, actually.
Yes. Sometimes we don't have all of things that in the other part, but it's okay.
Even we cannot. Basil, for the radiation, I was going to ask you that question. How do you start? Where do you put the Eylea, or where do you put the Avastin? When do you switch to Eylea? When do you switch the Avastin for the radiation retinopathy?
Yeah, so that's another good question. So I start out with Avastin as my primary approach, and that's for a few reasons. It's the cheapest medication, it's the easiest to get, and insurances are less likely to give you a problem with it, at least in the States. And I give them a few injections. If they have active disease, I'll probably give it 3 injections. And if I don't see a significant response, then I'll likely switch to a stronger medication, usually to aflibercept or Eylea. And then I'll give that 3 injections as well. If I really see no change whatsoever, then I will consider switching over to a steroid to try and work on some of the other cytokines. I don't know if it's accurate or not, but in my mind, diabetes has about 1/3 of cases that don't respond very well to VEGF. And I view radiation retinopathy somewhat similar because it's damage to the blood vessels in a similar way, except it's kind of localized. And so I think maybe there's a percentage of these radiation retinopathy cases that are not responsive to anti-VEGF, and that steroids might be a better approach for them. So, so I switch over. Almost always, the OCT will look better, but the vision does not improve.
Yeah. So. How do you do, Lauren?
Yeah, my drug of choice is always going to be Avastin. That's just like Basil said, it's really the easiest drug to get. It's going to be covered. Patients do not like when they get a big bill for something like Eylea, and I have gone to Eylea when we need to, when Avastin just isn't working, but it is a fight with insurance here. I don't know if I'm sure you've fought that fight, Basil. I see it. It's not easy to get them to pay for it. And here we do all of our injections in an injection clinic. So, it's not only the cost of the medication, it's also a facility fee. So it's actually very expensive if it's not covered for the patient. So I really, really never want to commit somebody to that.
How is in the South America? Do you have the access to Eylea, or is it just the Avastin right now? Or?
No, yes, we have access to Eylea too. Yes, but as Basil said, we first start with Avastin.
Yeah, that's the same for me here also. We start with Avastin, and then if patient doesn't respond, to try to get the Eylea. But Eylea is a big. The insurance don't want to pay it. Basically, they really put lots of trouble in front of you to get over it, and it's very expensive for the patient to cover out of the pocket, actually. But yes. do you see a difference between Eylea and Avastin?
So that's another good question. So Amy Scheffler in Houston looked at aflibercept and looked at ranibizumab, so both Lucentis and Eylea. And it seems like they both work really well. We just don't have a heavy patient load to compare up front. Again, extracting from what we have from diabetes, maybe there would be a little bit of a benefit, particularly in the cases where there's worse disease. And I'm really hoping that the big study that's coming out will provide a little bit more information. If I had to guess, I would say yes, probably Eylea would work better. How much better, I don't know.
Yeah, I agree. I definitely agree.
All right, everybody. Oh, do you have more questions, Dr. Dimitri? It's okay.
No.
So I'm interrupting again.
No.
So we came to the end of this webinar and great discussion with you guys. And I'd like to thank again everybody that participated, and thanks Dr. Balvin, Dr. Dimitri, Dr. Williams, and Dr. Gentile for being here with us today. And remember, everybody, send our cases and have a good evening. So bye, everyone.
Thank you very much.
Thank you all.
Bye.
Take care. Have a
Thank
good night.
you. Thank you. Bye.